am Dr. Srikanth. I am starting a new series of videos based on Harrison 21st edition. I will be focusing on important tables, important areas in Harrison 21st edition. The discussion would be beneficial for MBBS students, PGs, as well as super specialty students. So please subscribe to my channel and share it with your friends. Let's begin with today's discussion. Today, we will be discussing an important topic from HIV called immune reconstitution inflammatory syndrome. Immune reconstitution inflammatory syndrome, in short called as IRIS. A patient is diagnosed with HIV and you decide to treat him with antiretroviral therapy. So, ART is initiated in the patient. After initiation of ART, maybe after few weeks or months, patient develops IRIS. IRIS is basically of two types, paradoxical IRIS and unmasking IRIS. So what is paradoxical IRIS? So if you see in this flowchart, the patient is started on ART. After few weeks or months, if the iris is related to a known pre-existing infection or neoplasm, it is called paradoxical iris. Pre-existing infection may be a improperly treated infection or an untreated infection. Iris associated with a previously undiagnosed condition is called unmasking iris. The most important thing you have to remember is IRIS is most commonly seen in HIV patients when the CD4 cell count is less than 50 cells per microliter. IRIS can occur from 2 weeks to 2 years following the ART initiation. I'll explain IRIS in simple terms. A patient is started on ART. After starting of ART, HIV RNA levels drop because of the ART. As the HIV RNA levels drop, the immunosuppressive effects of HIV are controlled. The HIV has some immunosuppressive properties on our immune functions. So, when we are starting ART, those immunosuppressive effects of HIV are controlled. When the immune system improves, there might be a flare of an autoimmune disease, or there might be a resurfacing of any underlying untreated infection. This is IRIS in simple words. The clinical features of IRIS include lymphadenitis, prolonged fever, pulmonary infiltrates, hepatitis, increased intracranial pressure, uveitis, sarcoidosis, and Graves' disease. Important point to remember here is the underlying mechanism of this IRIS is similar to type 4 hypersensitivity reaction. And in severe cases of IRIS, we have to use glucocorticoids for the treatment. So, the take home message is IRIS is immune reconstitution inflammatory syndrome. It is most commonly seen when the CD4 cells are less than 50. It is of two types, paradoxical iris and unmasking iris. It is similar to type 4 hypersensitivity mechanism, and in severe cases you need to treat the patient with glucocorticoids. So that's it related to immune reconstitution inflammatory syndrome. Small note on inflammatory markers ESR and CRP. ESR is erythrocyte sedimentation rate and CRP is C-reactive protein. Both are measures of inflammation. ESR is an indirect measure of inflammation and CRP is a direct measure of inflammation. The point to be remembered here is ESR changes slowly. So you need not send samples daily for monitoring of ESR. Weekly samples is sufficient, but CRP changes very rapidly. So you can monitor daily. Both ESR and CRP are sensitive markers but not specific. And other potentially useful markers of inflammation are procalcitonin and serum amyloid A. These markers are most commonly used in private practice more than in our government hospitals. And also their clinical utility requires further more validation before widespread use. For now, ESR and CRP will be sufficient. So that's it for today. Thank you for watching till the end. Have a good day.